Hello again and welcome back to Advanced Human Gross Anatomy. Today we're going to spread our interest into the lower limb. We'll talk about the superficial and skeletal aspects of the lower extremity. We'll also talk about the anterior and medial thigh today. And then we'll end with a little bit of review from the gluteal region as well. Most of your life, I bet, you have called your lower limb your leg. And that's only partially true. The major joints of the leg separate other compartments here. So from the hip to the knee, between those joints we call the thigh. Between the knee and the ankle, we call that the leg. There's your leg. And below the ankle, we'll call the foot. So from the hip to the thigh to the knee, leg, ankle, and foot. So those are the actual components that we'll be discussing. There are some important superficial structures that we'll talk about here. In the extremities, typically we have veins that accompany arteries with the same name. Veins tend to be a little bit smaller, but not to be discounted. Much of the blood supply is returned through these superficial veins. In the leg, we've got a big one coming off the dorsal venous arch here on the medial side called the great saphenous vein. This one is a big one. Actually helps drain the medial portion of the foot, the leg, and then makes its way posterior to the medial portion of the knee, back up into the thigh. It's got many tributaries kind of entering into it as it helps drain. Enters into the we'll learn about the femoral triangle right here in a little bit, but it enters then back up into the femoral triangle as the femoral artery and femoral nerve exit this area. The femoral vein is going to come back up into there. On the lateral side, we've got, coming off that dorsal venous arch, we've got the small saphenous vein. This is actually found on the back side of the thigh, right through here. As you can see, coming around and coming back up to the posterior portion of the thigh. It will empty into the popliteal vein behind the knee, but it comes off of the dorsum of the foot, traveling posterior to the lateral malleolus, and then coming up the posterior portion of the thigh. It's important when you're talking about veins, these are superficial veins, but the deep veins, it's important to keep the leg active and moving and not sitting for too long. Don't sit too long listening to anatomy lectures. You don't want the blood flow in these deep veins to get stagnant. Otherwise, you're prone to develop DVTs, these deep vein thromboses, which can be they can release and become these thrombi can become embolisms, and if those embolisms, an embolus, right, a moving thrombus, and if the embolus gets clogged up in a smaller artery, it becomes an embolism. Most dangerous of these would be a pulmonary embolism if that clot got released back into the heart via the inferior vena cava, through the right atrium into the right ventricle, through the right ventricle, out the pulmonary trunk into the pulmonary arteries. If it gets into the lungs, then it gets really small. Those tributaries get very tiny, and that embolus can get clogged and become a pulmonary embolism, and that can be fatal. So good to keep active those deep veins, preventing them from developing clots. Let's talk about a couple of nerves here. The sural nerve is on the posterior aspect of the leg here as well. This is going to provide mostly sensory information. It's found on the back of the leg, ascending with the small saphenous vein toward the popliteal fossa, the sural nerve. Posterior femoral cutaneous nerves. These are nerves that come off of the sciatic nerve in the gluteal region, providing mostly sensory information to the back of the thigh. There's cutaneous branches of the dorsal rami. Remember the dorsal rami of the sacral and lumbar region from the cord. These are providing sensory information to the back of the buttocks here. So we'll be able to maybe see some of those terminal branches as we dissect down today. The saphenous nerve, let's maybe find a better shot of this. The saphenous nerve is going to follow the great saphenous vein coming up here, supplying sensory information to the thigh, but mostly to the medial aspect of the leg and the foot, coming way down here, that saphenous vein, saphenous nerve, following that great saphenous vein. The femoral nerve, which isn't shown on this picture, we'll talk about that more in a little bit here, but remember that passes through the psoas major muscle in the pelvis before running between psoas major and iliacus, so you'll be able to find that. And that provides motor and sensory information to the hip flexors. So we'll talk about the pectineus today. We've already talked a little bit about iliacus. We'll talk about sartorius. And then the knee extensors, the quadricep musculature. So that's going to provide sensory and motor information to that. That's the femoral nerve. Superficial fibular nerve, or if you have an older textbook, superficial peroneal nerve on the lateral aspect here. This is motor and motor information, motor output to the fibularis longus muscle on the lateral compartment. We've talked a little bit about the dorsal venous arch. Just going through the terms list here. The dorsal venous arch is where the return of the blood flow starts back into the venous system. So on the medial side, we talked about that turning into the great saphenous vein. On the lateral side, coming posterior to the lateral malleolus, up the posterior aspect of the leg being the small saphenous vein. So we'll be able to see that. The inguinal nodes we've discussed in a previous dissection, but these deep and superficial inguinal nodes that we've seen before, these are responding to infection. The superficial nodes, as we dissect more kind of around that inguinal canal today, we may find, rediscover some of those. These are going to be irritated, or they'll get inflamed with infection coming from the external genitalia, as well as just the lower extremity coming down below that. The fascia lata is this dense connective tissue wrap that kind of surrounds the thigh. So when we talk about the structures that we'll see today, after you remove the skin, this will be what you have to kind of cut through to get down to these deeper layers. It thickens, especially laterally here, as the tensor fascia lata, a muscle that we'll learn in a little bit, from the front side here comes down inferior and laterally toward the greater trochanter. On the back side, you'll see the gluteus maximus coming around, and then here you see that fascia lata, that dense kind of thickening here as it comes down toward the iliotibial band on the lateral side of the thigh, down through here. Let's just review some of the skeletal musculature, or not musculature, the bony structures here, the skeletal structures, to get our review here. Let's first look at the pelvis. Just a couple of things today to be mindful of. The anterior superior iliac spine. You can see this bump on the front side here. That'll be a muscle attachment site that we'll talk about for a couple of muscles. The head of the femur, right here, as it sits into the acetabulum of the pelvis. The head of the femur has, just lateral or distal to the head of the femur, has the greater trochanter right here, big source of muscle attachment, big site for muscles to attach there. And then the lesser trochanter, you can see a little bit of it here. I think if we isolate the femur, a little bit easier to see that more on the back side here, that lesser trochanter site. Here, again, a site of muscle attachment. On the distal ends of the femur, we'll talk about the medial and lateral condyles. This is going to be sites of articulation. So condyles, whenever you see that word condyle, it's going to be articulating with something else. So the medial and lateral condyles of the femur, we'll talk about articulating with the medial and lateral condyles of the tibia in just a few moments. On the posterior side of the femur, in lab, when you hold up a femur, it's always good to know, is this a left or a right? And one of the ways I can tell if it's a left or right femur is always by the linea aspera, this line, this ridge, this kind of V-shaped ridge on the posterior aspect of the femur. Once you identify that, you know that that's the posterior side, and then you'll be able to tell that in this case, obviously, it's a right femur. But this is, again, a site of muscle attachment for the adductor muscle group particularly. At the end of that, you'll see this adductor tubercle, kind of just superior on the medial side, superior to the medial condyle of the femur on the posterior side, the adductor tubercle. Let's talk about the patella, the kneecap, this sesamoid bone. It's actually a bone that doesn't actually connect to any other bone. It's housed inside of the tendons of the quadricep musculature. Actually, you don't actually have a kneecap when you're born. This dense mass of tissue in this area will eventually ossify and become the patella early in childhood. But it is I think it's the largest sesamoid bone of the body. It's kind of a pie shape to it. When we cut the patellar ligament and lift up, we'll be able to kind of see the kneecap housed inside of the tendons of the quadricep musculature, though. They provide strength and another site of attachment and kind of a pulley for those systems to work on. Looking at the tibia, this is now the femur would sit on top of here, so you've got the medial and lateral condyles of the tibia, where the medial condyle of the femur and the lateral condyle of the femur would sit. The big portion down here, just distal on the anterior side here, but distal to the condyles, is the tibial tuberosity. This is kind of ascribed typically as the common insertion of the quadricep musculature, but you'll notice today that the quads actually have an extensive insertion across the condyle of the tibia. That doesn't just attach to the tibial tuberosity, but oftentimes you'll see people will say, oh, the quadriceps just attach to the tibial tuberosity. That's true, they do, but you'll see today that they've got a broad insertion coming off of the anterior tibia as a whole. The fibula, kind of a lateral bone here. It actually does not attach to the femur. It's not part of the knee joint specifically, but it attaches to the inferior aspect of the lateral condyle of the fibula here, and that's going to just act as a support to the knee joint under the lateral tibia. So we'll learn more about the skeletal structures of the ankle and foot later on when we talk about the foot, but let's keep rolling here. Now we're going to talk a lot about these structures on the inside of the thigh, but the thing with this is that you're not going to be able to necessarily find these structures particularly. It's not going to look quite as good as Netter has drawn it here. It, hardly ever does, but what you'll do is you'll want to take there's what's called the femoral sheath, which is going to be around this, and you'll take a blunt probe, and you're going to kind of start teasing down this. Take a blunt probe, start teasing these structures apart more longitudinally, kind of stroking it down this way to tease out these structures. This will kind of look like one particular structure initially, kind of one tube here, but you'll actually find the femoral nerve and artery and vein individually within this femoral sheath here. So what you're going to do is make an incision. Actually, today first you'll make an incision down the anterior portion of the thigh, just kind of cutting straight down all the way down to the leg, and remove all of the skin from the leg, from the thigh and the leg, all the way from the ankle to up to the hip. Okay, you're going to put all of that skin in the container for the safekeeping of tissues. We won't be needing that anymore. I think we've discussed and talked about the skin enough at this point, so we can kind of get rid of that. We will at this point be wrapping the leg though with a towel to keep it from drying out. So we'll kind of dampen the towel, keep it moist, and keep that tissue from drying out too quickly over the time here. So but we won't be needing the skin on the leg that you'll be dissecting today. So looking at the femoral triangle again, you'll be looking for these femoral nerve, artery, and vein, but you're going to find just one structure here. It's going to be kind of frustrating. You'll say, I don't know this is what we're really looking at. But again, if you take that blunt probe and just kind of tease this out, you'll eventually start to discover, or you'll expose these three individual structures within this femoral triangle. Okay. You want to do this actually pretty close to the inguinal ligament, because what you'll find is that femoral nerve will quickly kind of explode into lots of smaller branches down the thigh. So you've only got about an inch distal to the inferior to the inguinal ligament here before that femoral nerve happens. So try to get that before it splits into all these sensory and motor branches going toward the anterior thigh here. Okay, so that's the femoral nerve. We'll talk a little bit more about that. But the femoral artery, let's find that femoral artery. The first big branch here off the femoral artery is going to be the profunda femoris. This is another name for it would be the deep femoral artery. This is just a branch off of the femoral artery. It supplies mostly the posterior and medial compartments of the thigh. There, but the femoral artery, if we trace that down from the femoral triangle, we'll continue it down. It'll supply mostly the anterior thigh compartment. It eventually will come down here and pierce through the adductor magnus muscle, through the adductor canal, or sometimes called the Hunter's canal, or not the Hunter, just Hunter's canal. These proper names. We're trying to get away from proper names in anatomy, but haven't quite got there. And it'll end up, after it pierces through adductor magnus, it'll end up into the popliteal fossa, where it changes its name to the popliteal nerve, and then that will split, going toward one branch will go toward the front of the leg, and one branch will sit in posterior aspect of the leg. Those are the anterior and posterior tibial nerves, but the femoral nerve coming down, piercing through adductor magnus, becoming popliteal nerve, or popliteal artery, hopefully I called that artery, into the popliteal fossa. The deep femoral vein just accompanies the femoral artery. You can see that here, this deep femoral vein, as it enters back in towards the inguinal canal and emptying eventually into the external iliac vein, up into the abdomen, or into the pelvis here. So the deep femoral vein. A little bit more about the profunda femoris here, the deep the deep femoral artery. This is going to have two branches. If you find that first branch off the femoral artery, the deep femoral artery, you'll see the two branches here. One's going medial, one's going lateral. These are the lateral and medial femoral circumflex arteries. These are actually going to surround the head of the femur here to bring nutrition to that. So again, we've said this word before, but all of this is happening within the femoral triangle, which is this space here. If you were to take, even just sitting, maybe you're sitting, if you take your leg, kind of flex the thigh and abduct it a little bit, kind of externally rotate, you'll feel this kind of void, this triangular space inside here between the sartorius muscle, kind of this muscle we'll talk about later on, the iliopsoas, and the pectineus muscle here. The adductor longus is probably what you're feeling first, and the sartorius, kind of that V shape here, and that's all happening right within that area. Let's see, what else can we talk about here? Well, this might be a nice shot of the profunda femoris, specifically the medial and lateral circumflex arteries, giving nutrition to the head of the femur down here. So profunda, giving those branches, and then the femoral artery itself coming down, piercing adductor magnus here, changing its name down into the popliteal fossa as the popliteal artery that way. The intermediate and medial cutaneous nerves of the thigh. These are branches of the femoral nerve as it comes down here. These are going to be, we'll discover these in the superficial fascia and the anterior thigh. Most of these will have been kind of pulled off or removed when you took the skin off of the anterior thigh, but we may see some twigs kind of popping out from the musculature here, showing signs of those intermediate or medial cutaneous nerves from that femoral nerve. Again, adductor's canal, you can see here where the femoral artery pierces through the adductor magnus muscle on its way into the popliteal fossa. Okay, let's talk about some musculature here. Well, we'll get to that in a minute here. Let's talk about some musculature. The quadriceps musculature. Quadra, four, sept is a Latin word for head. Quadricept, a four-headed group here. This helps extend these muscles on the front of the thigh, help extend the knee. But then there's another function of them too. They also help flex the hip. One of these muscles is kind of a unique one. It will actually cross the hip joints and attach to the femur. So if we look at the rectus femoris here. Rectus means straight. So you can see the front middle thigh muscle here. This one actually attaches to the anterior superior iliac spine, the ASIS, and comes down, courses over the patella, again attaching to the anterior tibia toward the tibial tuberosity. But this one actually, it never touches the femur. It just, it acts more as a hip flexor because it crosses the hip joint, but it's also part of the quadricep musculature as a whole because it crosses the knee as well, so it'll help extend the knee. But it's a two-joint muscle, so it has its function at both of those joints. The rest of the musculature we call vastus. Vastus as a word just means large. So these all come off of the femur. So the vastus medialis is the muscle on the inside here. Vastus lateralis on the outside here. You can see their fiber orientations coming a bit at diagonals. And then if we get rid of rectus femoris, this picture here shows the vastus medialis and the vastus lateralis, but the one underneath the rectus is what you're seeing here. This is the vastus intermedius. So imagine rectus femoris on top of vastus intermedius. And we've just removed the rectus femoris for this picture. But they all come from the femur and eventually attach down at different angles toward the patella at the quadricep tendon here, and then continuing over the patella onto the anterior aspect of the tibia. Okay, so mostly knee, the primary job, knee flexion, knee extension, secondary job, hip flexion because of its attachment from the rectus femoris. The adductor group, you can see if I have a better shot of the adductor group here. The adductors here, the first one again that you're going to feel, this adductor longus, coming off of the pubic ramus, going toward the linea aspera on the posterior aspect of the femur. The femoral artery, nerve, and vein all kind of sit, they're anterior to this, they lay anterior to the adductor longus. The most obvious one of the adductor group here. So this is going to be the one that you feel, probably the primary one that you feel in the kind of medial to the femoral triangle right here. The adductor magnus is the one below that. It's kind of, it's a large adductor muscle, but it's kind of under, or it's deep to the adductor longus, so you kind of have to move underneath of it. When we see a muscle called the adductor brevis in a little bit, after we've removed adductor longus, we'll be able to see adductor magnus much better. So this again is where the femoral artery is going to pierce through the adductor magnus on its way to the popliteal fossa. So you'll be able to see that one. Again, attaching from the pubic ramus down to the linea aspera, and then down toward that adductor tubercle as well. The sartorius, you can see the sartorius here coming again from the anterior superior iliac spine along with rectus femoris. This is going to course over superficially toward the quadricep musculature. So here you can see it's been cut, and here you can see the other side of it here, but it's going to course over the anterior thigh and then hook around the medial aspect of the femur and attach kind of to the inferior anterior medial aspect of the tibial tuberosity, kind of on the front side here. So that's a unique muscle. I believe it's the longest muscle in the body, from the anterior superior iliac spine, coursing diagonally, obliquely across the thigh, attaching into this pesa anserinus area here, where the anterior medial aspect of the tibial tuberosity. Okay, this vernacular for this would be the talar's muscle. Again, it never touches the femur. So imagine in the older days when tailors would have hypertrophy of this muscle because of all day laying the cloth between the thigh and the shin, underneath, over the thigh and the shin in order to sew. So if you're kind of cross-legged, kind of bringing this leg up like this all day, bringing the medial side of your tibia toward the lateral side of your pelvis, that's going to give that muscle some hypertrophy. If we look at the posterior view here, let's go back to this one. Maybe this here. You'll see the sciatic nerve. Nope. Where am I? Posterior view. Here you can see, here you go, sciatic nerve coming down right? You'll also see the popliteal artery and vein. Remember, that's just the coming back up through that adductor magnus, a continuation of the femoral artery and vein as they go through adductor magnus, so kind of that posterior side there. If we go back to the front, here you can see a muscle called the tensor fascia, tensor fascia lata, not to be confused with coffee drink from Starbucks, not a latte, it's a lata. This is going to innervated by the superior gluteal nerve. You'll remember that was the nerve that innervated the gluteus medius and minimus on the backside. It will help to flex the femur, but it attaches from the anterior superior iliac spine, again coming diagonally down the thigh. I don't know if I have a better shot of this. I really don't until we talk about the gluteal region. Can't really see it there either, but this is coming down diagonally, connecting with gluteus maximus from the posterior aspect. So imagine this coming from the front, glute max coming from the back, forming that IT band, coming down the lateral aspect of the thigh towards the lateral aspect of the tibia that way. So you'll be able to see that in the dissection today as well. The patellar ligament, or the ligamentum patellae, this is the central portion of the kind of the retinaculum of the quadricep musculature coming down to, as they attach to the tibia. Remember, we call it a ligament because it attaches from a bone to a bone. The quadricep tendons up here from musculature to the tibia, or to the patella, that's the quadricep tendons. The quadricep, or the patellar ligament, we used to call this the patellar tendon. Now we more accurately call it the patellar ligament because it's connecting from the patella, which is a bone, to the tibia, which is a bone. This is often harvested during ACL reconstructions to get what they call a BTB graft here, a bone tendon bone graft. They'll kind of take a nick off of the patella and a notch off the tibia, and then they have this nice, strong, dense, regular connective tissue graft with two bony graft sites already attached to it. So that's one way to, one of many ways to graft a tissue for ACL reconstruction. Let's talk about the more of this anterior compartments here. The pectineus. I want to go back to the femoral triangle though to see it. Well, here you can see it just kind of all by itself. The pectineus muscle right here. This is going to be again where the femoral artery, nerve, and vein all sit kind of across this, kind of the iliopsoas and the sartorius coming this way, and then the pectineus coming this way, adductor longus. There's that femoral triangle again, and you'll see through that inguinal ligament the femoral artery, nerve, and vein sitting right across this. But the pectineus, again, from the superior ramus of the superior pubic ramus here, coming down again toward the linea aspera on the back side of the femur. So it's part of that adductor group of muscles in the medial compartment. And then the gracilis, here you can see coming from, gracil means strap, so you can take a look at this one. Maybe here's a better shot of gracilis where sartorius isn't in the way. Pectineus here, adductor longus right here, and then gracilis coming straight down this way. This is going to act as an adductor of the thigh, but it doesn't attach to the femur, so it's not actually part of the adductor group. It doesn't attach to the linea aspera, but it comes from the pubic ramus down again. Remember we talked about sartorius entering into that inferior aspect of the anterior tibia. That in that pes anserinus, that's going to be another tendon that attaches there. So sartorius and gracilis come into there. Also, we talked a little bit earlier about, maybe we'll talk later, I forget where we are here, about the semitendinosus. We'll talk about the hamstrings in a later dissection and how those will attach. Well, the semitendinosus is the other one that will attach here. Pes anserinus means the foot of the goose. In Latin. So that's kind of what people looked at that and said, oh, these three tendons, sartorius, gracilis, semitendinosus, that all kind of looks like a goose's foot. Why don't we call that the foot of the goose? So the pes anserinus down there. So that's where the gracilis attaches. Adductor brevis. Okay, let's talk about brevis finally here. So here you can see Netter has cut adductor longus, and here he's kind of reflected it back. So here would be the extension of adductor longus. Here's the proximal attachment, distal attachment. Deep to that is the adductor brevis. Comes a bit at a steeper angle, sharper angle from the pubic bone here down toward the posterior femur on the linea aspera as well. And then here's maybe a better shot too of adductor magnus. So you can see how it's kind of underneath or deep to more broad insertion on the linea aspera of the adductor magnus muscle here. Okay. Obturator externus, another one here. Remember the obturator foramen, where the obturator nerve pierces through. That comes down and innervates the anterior, not the anterior, but the obturator nerve. You can see branches of it here coming down, innervating the medial portion of the thigh for sensory information. That's where that's coming through. But here's this muscle, the obturator externus, covering the external portion of the obturator foramen. Okay, let's now turn our attention to the gluteal region. As a review, now hopefully some of this is going to be review. The gluteus maximus, you can see that's been reflected off. Remember we dissected that, has that extensive origin off of the sacrum and the ilium, inserts kind of coursing over the greater trochanter on the outside here, courses on more laterally this way, but it doesn't actually attach to the femur that way. It inserts kind of into the iliotibial band, where the tensor fascia is coming from the front, the gluteus maximus comes from behind, and together they kind of insert onto that iliotibial band, coursing across the trochanter. Now, it attaches to the side, kind of over the side of that, so it is kind of a there's a bursa that sits right on the outside of the greater trochanter. So with extra use of the gluteus maximus, if you go to the gym and really work out your glutes, doing some steps or stairs or lunges or squats to get that glute engaged, or if you're just moving, if you're using your glutes poorly, that poor activation will also lead to irritation at this bursa that sits on the outside of the greater trochanter. Remember that bursas are these synovial fluid-like sacs that sit over bony prominences to protect underlying or overlying structures. So the soft tissue structures. The gluteus maximus will sit over the bursa, which sits over the greater trochanter. So you don't want that rubbing of that musculature over that bone. But too much of that can cause bursitis in that the greater trochanteric bursitis, or even tracing down into the lateral side of the thigh, you can get kind of those deep aches into the IT band. Whenever people come into the clinic and have IT band syndrome or irritation down the IT band, we always want to start looking proximally. What's happening up here? What's not moving well up into the gluteal region that might be causing that? And then you've got the gluteus medius and minimus. Here you can see the gluteus medius has been reflected off here. Here's a portion of it. Here's a portion of it to see the gluteus minimus underneath it here. Remember that these are attached to the anterior aspect of the greater trochanter, so they're actually going to medially rotate the hip in non-weight bearing. But their function, really, when we talk about legs, always think about them in weight bearing. The function of muscles of the lower extremity have their function, not necessarily their actions, but their functions. Now, that might be weird to think about those as different things, but their function would be in weight bearing. So their job really is to stabilize the pelvis. You think that's kind of weird, stabilize the pelvis. Why would those muscles they're we've learned them as medial rotators of the hip, but their function is when you step with the left foot, the right gluteus medius and minimus in this case will hold the pelvis parallel to the floor, perpendicular to the leg, and not allow that leg to shift out. So they're going to stabilize the pelvis to step. If you're going to kick a ball, everybody's looking at the leg that's moving to kick the ball. Really, the one doing the bulk of the work to stabilize the body to the earth, to allow the other leg to kick the ball, is the one that's on the ground. That leg's gluteus medius and minimus Their job is to hold that still. Otherwise, you get what they call a Trendelenburg gait, and I can mimic that in the clinic when we see, or in the lab when we see each other. But that was named initially from a 19th century German physician, Trendelenburg, who kind of identified that if there's a damage to the superior gluteal nerve where these muscles aren't doing their job, or if it's just poor movement patterns learned over a period of time, that you'll start to get that shift of the pelvis where you won't be stabilizing the pelvis as you step with the opposite leg. So we can talk more about that in the lab. Review of the nerves here. The sciatic, we've seen the sciatic coming down, but here's that pudendal. Remember the pudendal nerve coming out along with the sciatic nerve, looping around the sacrospinous ligament as it comes back around inside the sacrotuberous ligament toward the perineum. Toward the medial aspect of the ischium. Remember Alcock's canal in the ischial-rectal fossa. Remember all this? Hopefully that's being familiar. Where you can kind of stick your thumb in towards the medial rectal fossa, right in through here, so you can kind of notice where those nerves are. Nerves of the perineum. Let's see, sciatic we talked about. Looking at my list here, what else are we going to talk about? Near the sciatic here, again, you've got the piriformis. Remember, that's a kind of a landmark. The nerve coming above that, the superior gluteal nerve, giving innervation toward the medial, the gluteus medius and gluteus minimus. This way, and then below that coming down is going to be the inferior gluteal nerve, giving information to the gluteus maximus coming off this way. So that piriformis being the split there. I feel like there was something else I wanted to talk about, that sciatic nerve. Maybe not. Sciatic nerve, you can see most of it coming down below piriformis. There's some cases where the sciatic nerve will come kind of split, and half it will go above and half below the piriformis muscle. Sometimes in a small population, even that sciatic nerve will pierce through the piriformis muscle, and that can give rise to piriformis syndrome. So that's kind of an issue there. So yeah, that piriformis muscle, maybe we didn't talk about that again, but that piriformis is going to, coming from the anterior portion of the sacrum and traveling down toward the greater trochanter again, diagonally. So again, that piriformis syndrome is kind of it gets misdiagnosed actually quite often with that, but the piriformis being a big landmark here. So at any rate, the sciatic nerve is right here. Don't put your wallet in your back pocket and sit for long periods of time. Really don't put anything in your back pockets. You don't want any pressure point pushing up against this region for a period of time. We talked a little bit about posterior femoral cutaneous nerves here coming down off the sciatic nerve, giving sensation to the posterior aspect of the thigh. I think that's all I really want to talk about on that. Last thing, just a little bit here we'll talk about is the hip rotators from the posterior side here. You can see these hip rotators. We've seen a lot of them already, but the piriformis being a lateral hip rotator, and then just deep, so gluteus maximus, gluteus medius, gluteus minimus, piriformis. Now let's keep going down inferiorly. So below the piriformis, you've got the superior gemellus muscle, superior gemellus, and then you've got two below that is the inferior gemellus muscle. I learned this as the Gemelli brothers, these Italian brothers here that are always quarreling, and they need this superior. I'm sorry, they need this obturator internus muscle to kind of separate the two of them. So think about this as piriformis, superior gemellus, the obturator internus, covering the internal portion of the obturator foramen, and then the inferior gemellus here. So these are all coming from the ischial spine, those three going toward the medial aspect of the greater trochanter here. So again, superior gemellus, obturator internus, inferior gemellus, and then below that now we've got the Quadratus femoris. Again, here's another quadratus muscle. The Greeks in their shapes, they really liked four-sided muscles. There's a lot of quadratus muscles. Here's the one on the femoris. So this is coming again from the ischial tuberosity, going laterally toward the intertrochanteric crest of the femur, kind of inside between the greater and the lesser trochanter here. These are all hip rotators, are all lateral hip rotators. So deep into the gluteal region, covered all by the gluteus maximus. All right, if you can kind of see that. So all these muscles, very important if you want to do the hokey pokey at your friend's wedding next weekend. Okay, I think that's enough of you listening to me talk for a bit. I hope this was helpful. I'm excited to see you in lab today. Hopefully a good dissection of finding some of these structures that we've talked about. Thank you for your time. I'll talk to you later. Bye-bye.